Okay, so I guess, I mean, there's not. Hello, everyone. I'm Ulrich Sidney. Today we have a presentation by Dr. Toivo Hasheela, who's a neurosurgery resident, and he'll be presenting himself a little bit later on. So before we start, we're going to go around and have the panelists present themselves. Let's start with Zolo. Zolo, can you unmute and present yourself, please?
Okay, thank you. Hello, everyone. I'm Zolo Ivan. I'm a CTA medical student from Cameroon. I'm a member of the Association of Future African Neurosurgeons, and it is a pleasure for me to be here tonight. Thank you very much.
Thank you, Zolo. Then next up, Darwin. Darwin, can you please unmute and present yourself? Yes, Darwin.
Good evening, everyone. Thank you so much. My name is Darwin Chimba. I'm a medical student from Copperbelt University, and I'm a member of the Association of Future African Neurosurgeons. Happy to be here this evening. Thank you so much.
Thanks, Darwin. And finally, that will be me. So I'm Ulrich Sidney. I'm the founding president of the Association of Future African Neurosurgeons, and I'm currently a research associate at the Global Neurosurgery Initiative at Harvard Medical School. Today we have a presentation, like we said, by Dr. Toivo. Please go ahead, Dr. Toivo, present yourself and start your presentation.
Hello, everyone. My name is Toivo Hasheela. I'm a neurosurgery resident with the University of Zimbabwe, but I'm currently in Namibia. So tonight we are going to talk about clearing of the cervical spine after trauma. I thought it was a very important topic to talk about. And we're going to follow this outline. So,
sorry, Dr. Toivo, can you please go into presentation mode so we can have the slides on all the screen?
Okay, so you are not seeing the slides I'm sharing now?
No, we're seeing the slides, but they're quite small. So if you can click at the bottom right of your screen. At the bottom right of the screen, yeah, bottom right of the screen, you should see a square-like box there that says presentation. So the next, wait, the fourth one, yes, that one. Yes, that one. Yeah, yeah.
Slideshow.
Yeah, that one.
Oh, okay, great.
Yeah, perfect. Thanks.
Great. So yeah, let's carry on then. So I'm going to start this talk with a statement above, which I'm sure a lot of us have heard before. Every trauma patient has spinal injury until proven otherwise. It is very important for us as clinicians to be cognizant of this fact. As you can see on the pictures that I have put up there on that slide, most of the time the first encounter with patient in the emergency setup is in this form. The patient comes in this state, in this immobilized state. And this is usually the first encounter between the patient and the clinician. The patient is handed over by the paramedics in that state. And there's a particular reason and the transition from paramedics who put up all these immobilizing devices, the transition should be appropriate. Otherwise, you could have catastrophic and preventable situations if it's not handled accordingly. And this is what brings us to the topic of clearing of the cervical C-spine. So just, I have a lot of very young medical students on the platform as well. So it's important at this point for us that we are all on the same page. That's why I'm going to start with a definition. What do we mean when we talk about clearing of the cervical spine? So, really, in the simplest terms, by clearing the cervical spine, we simply talking about the act of spinal cord injury or spinal cord instability. And this carries a great amount of importance. It carries a great amount of importance because we can prevent exacerbating existing injuries that the patient might have suffered at the moment of the trauma. We can prevent causing new because of instability that the patient might have sustained from the trauma. And more importantly, also, we can prevent those complications of prolonged immobilization. We need to clear the cervical spine and remove the patient from the spine board and from the cervical collar if it's not necessary, because those devices are out without complications. Patients can develop pressure ulcers, prolonged cervical collar, application associated with things like increased intracranial pressure, so forth. So it's very important that we clear the C-spine, and not only do so, but do so in as early as possible. It's recommended that every patient every trauma patient's cervical spine should be cleared at within 4 hours. Now, just to highlight, I put up this slide specific just to highlight the importance of cervical spine protection. As you can see on the ATLS Protocol, which is the universal approach that is used for management of every trauma patient in the emergency department, you can see that cervical spine protection is equivalent or is equated in terms of importance to the airway. So that is how important cervical spine protection is. Because really, if it's not handled properly, you can have devastating outcomes for the patient. Right, now that we have defined what clearing cervical spine is, let's talk about how it's done. How do you then clear the cervical spine? So there are two widely used validated tools that are used for clinical decision making in terms of clearing the C-spine. That is NEXUS criteria and the Canadian C-spine rule. So what these criteria do, they help us to determine which patients we can confidently that they are unlikely to have cervical spinal injuries based on the history and clinical examination alone, and which patients we need to do radiological investigations for us to be able to confidently say this patient does not have cervical spine injury. So basically, these tools help us to divide our patients in two categories. So the first one we are going to look at, and one which is simpler and more practical than the other, is the NEXUS criteria. NEXUS criteria basically really is a set of 5 criteria of which, if the patient meets all 5 of them, then it means this patient, we can confidently say that this patient does not require imaging for the cervical spine. Now, what are those criteria? If the patient has normal level of consciousness, if the patient does not have posterior midline cervical tenderness, if the patient is not intoxicated, if the patient does not have focal neurological deficits, and if the patient does not have any distracting injuries that may be masking the cervical pain. Now, these distracting injuries, examples can be long bone fractures, for example, or degloving injuries, crash injuries, large burns. These are all significant injuries can mask the cervical tenderness and give us misleading clinical conclusions. And then on the other hand, we have the Canadian C-spine rule, which is a little bit more tedious, more accurate. It is more sensitive and specific than the NEXUS criteria, although a little bit more difficult to apply. So the NEXUS, the Canadian C-spine rule is basically a 3-pronged approach to the patient. I think I have a slide which is a little bit clearer. Okay, this one is clearer. So there are some conditions that must be met for us to be able to apply the Canadian C-spine rule on a particular patient. We cannot, for example, apply the Canadian C-spine rule on non-traumatic cases. The Canadian C-spine rule cannot be applied in patients that are under the age of 16, for example, or patients whose level of consciousness is impaired, patients who are unstable in their vital signs, okay, or patients who are pregnant, or patients with pre-existing cervical spine pathology. Now let's look at the process itself of applying the Canadian C-spine rule in a trauma setting. So, like I said, it's a three-pronged approach. The first question you are faced with is to determine whether this patient has got any high-risk factors, which makes radiography mandatory. Now, high-risk factors include things such as above 6 years, dangerous mechanism. By dangerous mechanism, we mean things like, apologies, dangerous mechanism, we mean like a fall from stairs, accidents involving bicycles, accidents involving motor vehicle accidents at speeds of more than 100 kilometers per hour, and so forth. Or patients presenting with neurologic deficits. These patients who demonstrate high risk factors, they go immediately to the radiology arm. Those patients who do not have these high risk factors, we then apply the second question. Do these patients then have the low risk factors, which allows us to say discharge them without radiology? Now, what are these low risk factors? These are patients who were involved in simple rear end motor vehicle collisions, patients who are able to sit up in the emergency department, patients who are able to ambulate, patients whose neck pain has a delayed onset, or patients who do not have any C-spine tenderness. So patients who demonstrate these low risk factors safely discharged without imaging. But if these low risk factors are also absent, then we have to go to the third stage, where we ask, sorry, I made a mistake there. If these low risk factors are then present, which means the patient at the risk of cervical spinal injury, it means it's safe for us to test the range in this patient. So we can then go to the test stage and ask the patient to actively rotate their neck 45 degrees to either side. If the patient is able to do that, then it means we are able to also discharge this patient without radiography. But if they are not able to, even at this stage, they still go back to their imaging arm. They should receive imaging. So this is the Canadian C-spine rule method. Now, once we have now divided our patients into two categories, those that require imaging and those that do not. For those that require imaging, what are the imaging modalities use in clearing the cervical spine. The imaging modality of choice really, when available, should be CT scan. CT scan, axial views, coronal and sagittal reconstruction, and should cover the whole cervical spine from the occiput to the upper thoracic vertebrae. So we say minimum from occiput to T1. And from left to right, that is the axial view, coronal view, and the sagittal view scans, normal images. No pathology on these. Where CT scan is not available, the routinely used imaging is in radiographs. And the three standard views are the lateral, the up mouth, and the AP views. So how do we interpret these images? Let's begin with the lateral views of plain radiographs. So there's an acronym that we can follow to help us not miss out any of the aspects. AACL. So the first A is adequacy. And this is what we are seeing here in the images that we are using as examples. On the left, you can, if you count your vertebrae, you can see that this image shows only up to C1, 2, 3, 4, 5. It only goes up to C5, C6 level. So this is an inadequate image, and one should not accept such an image because, as you can see, where it is marked in red, that is where the C7T1 junction lies, and there could be injury there that we cannot see. So we should not accept this as an adequate image, and the patient should be set back and on alternative image. Likewise, this is not an adequate and is not acceptable. Then the next A on our acronym is for alignment. Alignment we assess using four anatomical lines called the anterior vertebral line, the posterior vertebral line in yellow, the spinal laminar line, and the anterior spinous line. So these lines should form smooth curves. There shouldn't be any deformities along those lines. And then next, this is an example the pathological image. On the next, let B, which represents B is for bone. We are looking for fractures of the vertebral bodies, collapse, decreased vertebral body height, avulsion fractures of the vertebral bodies. And in this case, this is what we are seeing here. You can see that the anterior vertebral line does not form a smooth curve. There's a step deformity there, suggesting injury to that vertebra. Then we look at the cartilage. You want to look at your disc spaces. Do you have any reduced disc spaces or increased disc spaces that may suggest traumatic disc function? Look at your facet joints. They should be well aligned, and you look for patched facets, jumped facets. Then the last aspect of the lateral view we look at is the soft tissues, the retropharyngeal spaces. Those are the values that are supposed to be at every level. One can try and memorize that, but I'm going to show you something a lot easier to remember. This is a family we can generalize and say above C4, the retropharyngeal space should not be more than a third of the vertebra at that level. And below, it should not be more than 2/3 of the vertebra at that level. That can be a general guiding principle that is a lot easier to remember. Okay, then from the lateral view, we move to the open mouth view. The open mouth view, we are assessing really the C1, C2 complex. We want to make the distance between the lateral masses and the odontoid process or the peg is equal on both sides. Okay, so the lateral mass should be equidistant from both. So both lateral masses should be equidistant from their dens. If these distances are unequal, this suggests for example, rotator subluxation. The other thing we look at on mouth view is the alignment of the lateral margins of C1 and C2. These lateral masses should be in alignment. The lateral masses of C1 should, the overhang of lateral masses of C1 should not be more than 7 meters in total. Of the rule of sense. If you look at the diagram on the right here, it illustrates what we are talking about. So this overhang C1 beyond C2. The top overhang from the left and the right should not be more than 7. If it's more than 7, that indicates that there's disruption of the transverse atlantal ligament, which indicates pathology at that level. Then we look at AP view. On the AP view, again, we look at adequacy. It should cover the whole spine again, from occiput to the upper thoracic areas. We look at the alignment. The AP view, we use the spinous processes as well as the transverse processes. The transverse processes here are indicated by the red lines, and the spinous processes are indicated by the yellow markings. Again, the bone, integrity of the bone, we trace the cortical outlines of each vertebra and identify any fractures. The spacing between the spinous processes ideally should be approximately the same. If you have fanning of the spinous process, that suggests ligamentous injury. And then as soft tissues, we assess for surgical emphysema that can suggest also significant injury, blunt injuries. Okay, and then so those are the routine. Those we have talked about. Those are the routinely done views when we are clearing the cervical spine. But in cases where the lateral view is inadequate, one can request what is called a swimmer's view. A swimmer's view is basically an oblique view that is done with the aim of trying to get the humerus out of the way so that we can visualize the cervical thoracic junction. Right. And then, so basically, those are the routinely done investigations when we are clearing the cervical spine. But there are specials where, for example, we have sent the patient for imaging. We have done the routinely requested images, and they come back normal. We are still suspicious the patient has got instability. So in this case, we do additional investigations, and those can be in the form of MRI or what we call flexion extension dynamic radiographs. This is an example of an MRI example. So you can see, for example, on the left side, that there's no bony abnormality. So on X-ray, for example, and CT scan, you won't see any abnormality at all. But on this CT, so on this MRI, you can see that there's an area of hyperintensity around the interspinal ligament vicinity, which suggests ligamentous injury. This patient could have instability that won't show on plain radiographs, it won't show on CT scan, but if we do try, this is sequence with pressure, you can see that there's a real intensity suggesting injury, ligament injury, or you can have traumatic intervertebral disc disruption that can be retropulsed into the canal and compressing the spinal is evident in this MRI here. This you won't be able to pick up on X-ray or CT scan. So in this case, one needs to do an MRI. And then the other modality is the dynamic X-rays, in which and also pick up instability that is not obvious on the routine views. For example, in this flexion view, we can see that there's subluxation of C3, C4, C5 that was not probably evident on the standard views, static views. Oh, okay. So that is basically it that I had to say about clearing of the cervical spine. So now open up any questions or contributions that we may have from the.
Thank you very much. Thank you very much for the presentation, Dr. Toivo. So if there are any questions, you can send your questions in the chat, or you can raise your hand so that we get the questions. In the meantime, what we can do is we can get maybe some feedback from the more senior neurosurgeons and residents that are currently here. So I open it up to, I guess, Dr. Marco, Dr. Kabulu as well. If you have any feedback or additional information, wanted to share with them.
Buddy.
Hi, Dr. Marco.
First of all, thank you for your panel. It was absolutely very clear, and I liked the more common practical aspect in a patient with cervical trauma. I want to just highlight as a experience above all when you are a young neurosurgeon, that when you got a pediatric case of cervical trauma, we need to remember there are some variation. In particular, if you see a cervical X-ray in a children less than 8 years old, sometimes you can see there is a pseudo subluxation of C2, C3, and C3, C4. That's absolutely normal. Is less than 4 millimeters, but it's not a trauma luxation. More often is a normal finding. And above all, another aspect is the synchondrosis at the base of the odontoid. Just remember that until 8 years old, in a children, there is still the synchondrosis at the base of the dent. So sometimes an expert, a young, he said, neurosurgeon can change this synchondrosis for a odontoid fracture, second type, but it's not. So just to remember that in children we have some aspect we need to keep in mind when you examine these little patients.
Okay, thank you so much, Dr. Marco. Dr. Kabulo, is there something you'd want to maybe share or add on this? If you're speaking, you're muted, Dr. Kabulo. While waiting on that, are there any questions, perhaps? Anyone has a question they want to ask? Okay. All right, so my question, Dr. Toivo, will be, if you have like you said, if you have a medical student and you're and they're assisting you during, say, one of the calls, what would you expect of them as soon as from the moment you receive a patient with a cervical spine trauma? How would you, what can they do to be useful in a more practical way? Dr. Toivo? He's not muted, but I can hear him. Yeah, I don't know. Well, maybe some other residents from the continent. I don't know. I think the most senior here available is Dr. Robert. Dr. Robert, say you're on call and you have a medical student and you have one of these cases of cervical trauma. How can the medical student be useful to you? What do they need to do?
Okay, so thank you, Dr. Sydney. Normally, when we're working with medical students, first and foremost, okay, there are certain details that they may not really, I mean, they would be penalized if they don't know the Canadian spine rule. But if someone came in with a head injury or a polytrauma patient, or you have any reason to suspect that the patient might have had the ATLS spine, before you even send them for imaging, I think the most useful thing that you would generally be expected to do to stabilize that neck by putting a neck collar, a neck collar, a head collar, and then you can send the patient for imaging. Yeah, I joined the presentation a little bit late because I was held up somewhere, but generally if a medical student was able to do that, and probably pick a few things about alignment, you know, if for example, the medical student is on ground and they're able to send a patient for an X-ray, and they're able to recognize that maybe there is some degree of malalignment, they are not penalized a lot if they do not pick all the details, but at least that would be acceptable. In a setting where we have CT scan, in case we've, because we're in a resource limited setting here, even in Nairobi. So we usually want to send patients for X-rays if we're not really very sure that there is a C-spine injury. However, if there is obvious deformity or neurological deficits in the upper or lower extremities, then we expect them to think about the CT scan at that point. I think in my setting, that would be really acceptable.
So as a summary, from what you've said, the first thing is be able to recognize that there's a trauma and then stabilize the neck. And then the next one would be definitely to do a thorough examination to make sure that there's none of those deficits, because that informs the management, whether in a resource limited setting, you'll be asking for an X-ray or a CT scan. And then if they have they have to follow through on that exam and then make sure that there's no alarming signs. So that will be a summary.
Absolutely.
Okay. So I guess all the medical students are listening, and this is where you should be taking notes. So when you're on call, that's what, at the very minimum, that's what you should be doing. Awesome. Dr. Marvin, is there anything you want to maybe add or share on this? Yeah, just the question is cervical spine clearing. Is there anything you wanted to maybe add on this?
Okay. Well, I'm sorry I joined the presentation late. However, I have a question.
Yes.
Yeah. I got from the presentation, we could use a MRI when we think there is a cervical instability which wasn't seen in X-ray or CT scan. Well, the example he gave was an MRI with ligamentous lesion. I'm just a bit curious, like, I would like to know if it is possible to have cervical spine instability with just posterior ligamentous lesions without pedicle lesion or other articulation.
Since we have Dr. Marco here, maybe. So that I don't know if you heard the question, Dr. Marco. The question was about instability in the cervical spine and when we can get those instabilities. I guess the best way to answer this would be to go through the column models for the spine and when we can expect instability from the spine. If you can give us an overview on that, Dr. Marco, please.
Sorry, can you repeat?
So the question is about instability on the spine. Which are those elements that when they are injured, we'll expect instability at the level of the cervical spine in general?
Well, first of all, you need to identify the anatomical zone where there is a fracture, where there is a luxation. That's allow you to identify if there is instability, because if you got just a fracture of the vertebra, a little, a very slim plate fracture, usually is not instability, and patients recover well with collar. But if you find some aspect, that could be the drop fracture, Remember, drop fracture is very important because it is sometimes a sign of longitudinal anterior ligament distortion, so instability, anterior instability. If you find a luxation, that could be the unlocked fracture. Unlocked fracture is definitely instability. Sometimes you got also root involvement and need surgery. And so if you got this aspect, send the patients for MRI immediately, and then examine if there is there are some aspect like could be ligament damage. In particular, you can see here in the ST IR sequence. And another things, as you just liked, Rick, is the examination of patients. One of the things that could be very helpful, the young medical doctor, is a first examination of patients. If the patient find he move his head, but legs, try to move the legs, he cannot move, oh my God, there could be a central myelopathy. So you need to be sure the patient is locked with the collar and send to MRI.
Okay. And more specifically now about what Dr. Marvin was asking now is, so from what you've explained, can we have a lesion of the posterior longitudinal ligament with no pedicle lesions and have an unstable cervical spine? Is that the question, Dr. Marvin?
Yeah.
Yeah. So can we have a posterior longitudinal ligamentous injury with no bony lesion and have an unstable spine?
Well, is possible because posterior longitudinal ligament injury sometimes is caused by a flexion and anterior vector. So usually is sometimes a cause of instability. In this case, I suggest to perform of course, MRI and say morphodynamic sequence with doctor assistance. Remember that never send the patients alone in radiological department. Follow the patients, say the patient flex. If the patient said, doctor, I feel brachialgia, I feel neuralgia, that's already a sign of instability. So shot the picture in this moment, the X-ray, and examine, and it usually is a good way to proceed in my personal experience.
Okay. Well, does that answer your question, Dr. Marvin?
Yeah, definitely.
Okay, thanks. So Dr. Gideon had a question. If you can unmute yourself, Dr. Gideon, present yourself and ask, please, your question.
Oh, okay. Hiya. I'm not actually a doctor. I'm still a medical student.
Okay.
And my question was sort of more general. So I wanted to know what is the most common nerve root that's compromised in C-spine injuries? Is there in any of your experiences? And what is the presentation of that compromise? So is there something that you usually look for first when you see a C-spine injury that sort of denotes its severity? That makes sense.
You're muted, Dr. Marco.
Okay, can I answer? Well, in my personal experience, and more in particular in literature experience, the most common involved roots are C5 and C6, but usually is caused not by root avulsion, but by traction. That's because some author explained this in an anatomical view, because when you go from the upper cervical level to the subaxial, so C5, C6, you got a foramina that is more longer than up, and sometimes there is also a membrane, a ligament that keep the nerve very close to the bone. Sometimes when you got a cervical injury, that involve also a distraction because the patient fell and there is a distraction in the brachial plexus. You got also traction of the C5, C6 more in particular. And sometimes, so they are the most involved routes in my personal experience. I got also a patient, maybe in next panel I show you the picture. He was involved in he fell down in a mountain walking, a fracture of C5, C6 with instability. So I perform arthrodesis from anterior aspect. But the patient has a paralysis of deltoid, so abduction and biceps. So this patient, as testified by the electromyography, was involved in C5, C6 traction. Probably there is a neuroma in continuity, so these patients will be sent for a nerve transfer in this case. It's an interesting case.
Yeah, we'd love to learn about that that case.
Yeah, I don't have the picture here, but I promise I show you. Even because in my next panel I wanna talk about the brachial plexus in my series about peripheral nerve surgery. So it definitely will be an interesting case for the panel and for all of you.
Awesome. I hope you're satisfied, Gideon.
Yes, very satisfied. Thank you so much.
Okay, awesome. Yeah, I mean, if there's any other questions, please feel free to ask your questions. We had lost Dr. Toivo. I think he's back now. Probably an issue with his connection.
Yeah, I had lost my connection there, but I managed to sort it out. I'm back on the panel now.
Yeah, so we just had when you were away, we just had a few questions from the panelists that were answered by Dr. Marco Meloni. Basically, the first question was about instability of the cervical spine and which elements needed to be injured before we could have an instability. So we had a good overview on that. And then the next question obviously was, we had equally a question about what medical students were expected to know and do in this setting as medical students alone practically. So we had a good answer here from Dr. Kaduyu, and the last one which you assisted from Gideon.
Oh, okay, great. We are honored to have senior colleagues who can assist us with pertinent questions like that. Thank you very much. Thank you, Dr. Marco.
Thank you too.
Well, thanks. I guess there's no other question. If any question comes after this, feel free to send them in the WhatsApp group. And we keep inviting everyone to choose one of the themes on the timetable, on the schedule, and present, because this is the best way to learn. We get to see what we need to improve on, and we equally get to practice presenting. So thank you so much, Dr. Toivo, for taking the time to do this. And have a good weekend and stay safe.
Thank you. You're most welcome. Pleased to be on this platform. I'm new here. So if my presentation was not on the right level that is expected, I was not very clear who my audience is going to be constituting mainly. But I've tried to keep it at a level that even the most junior medical students now can follow. But I think this is a good initiative. Let's keep keep it up and develop it further.
Well, thanks. We're happy to have you. Thanks.
Thank you.